Hello everyone, my name is Rohit Kalane and my topic is antifungal drugs. In this we will cover heterocyclic benzofuran, azoles, allylamines and topic related 5 MCQs. Antifungal drugs. Infectious diseases caused by fungi are called mycosis and they are often chronic in nature. Fungal infections occur due to abuse of broad spectrum antibiotics and decrease in patient immunity. Now we will see classification based on structure. First is antibiotics and it is classified into polines and heterocyclic benzofuran. The examples of polines are amphotericin, nystatin and hamicin, and the example of heterocyclic benzofuran is griseofulvin. Second is antimetabolite and the example is flucytosine. Third is azoles and it is classified into imidazoles and triazoles. The examples of imidazoles are ketoconazole, clotrimazole, oxyconazole and miconazole, and the example of triazoles are fluconazole, itraconazole and voriconazole. Fourth is allylamines and the examples are terbinafine and butanafine. Fifth is echinocandins and the examples are caspofungin, anidolafungin and micafungin. There are other topical agents such as tolnaftate, anticyclinic acid and benzoic acid. Now we will see heterocyclic benzofuran, griseofulvin. It is an fungistatic drug and has a narrow spectrum activity. It is given orally and absorption increases with fatty meal. Griseofulvin has a half-life of 26 hours. It is taken selectively by newly formed skin and concentrated in the keratin. It induces cytochrome P450 enzyme and it should be given for 2 to 6 weeks for skin and hair infections to allow replacement of infected keratin by the resistant structure. Griseofulvin inhibits fungal mitosis by interfering with microtubule function. It is used to treat dermatophyte infections such as ringworm of skin, hair and nails. It is highly effective in athlete's foot. Griseofulvin is ineffective topically and it is not effective in subcutaneous or deep mucosis. The adverse effects of griseofulvin are peripheral neuritis, mental confusion, fatigue, vertigo, GIT upset, enzyme inducer and blurred vision. It also increases alcohol intoxication. Now we will see clinical uses of griseofulvin. It is effective in aspergillus and candida infections. It is second line for those who have failed or cannot tolerate amphotericin B or itraconazole, and the adverse effects are nausea, vomiting, flushing. Flushing is due to release of histamine from mast cells and it is very expensive drug. Azoles. These are synthetic antifungals and has a broad spectrum activity. It may be fungistatic or fungicidal depending on the concentration of drug. It is most commonly used and azoles are classified as imidazoles and triazoles. Imidazoles. It has 2 nitrogen in structure. Imidazoles which can given through topical routes are iconazole, miconazole and clotrimazole. Ketoconazole is given through systemic route. There are newer drugs such as butaconazole, oxyconazole and sulconazole. Triazoles. It has 3 nitrogen in structure and the examples are fluconazole, itraconazole and voriconazole. Turconazole. It is used to treat superficial infections and it is given through topical route. Both these groups are structurally related compounds, has same mechanism of action and has similar antifungal spectrum. Now we will see imidazoles. Ketoconazole. It is first orally effective broad spectrum antifungal. It is effective against dermatophytosis, deep mucosis and candidiasis. Ketoconazole inhibits cytochrome P450 enzyme which is necessary for conversion of lanosterol into ergosterol. Thus it inhibits the synthesis of ergosterol and disrupts the membrane function and increases membrane permeability. Pharmacokinetics. It is effective orally. Acidic environment favors its absorption. It has high protein binding capacity. It gets readily distributed in our body and doesn't cross blood-brain barrier. It is metabolized in the liver and excreted in the bile. It has T half-life of 8 to 10 hours and dose equal to 200 mg once a day or twice a day. The adverse effects of ketoconazole are nausea, vomiting, anorexia, headache, paresthesia, alopecia. It decreases steroid, testosterone and estrogen synthesis. In males, it causes gynecomastia, oligospermia, loss of libido and impotence. In the females, it causes menstrual irregularities and amenorrhea. It increases liver enzymes and causes hypersensitivity reactions such as skin rashes, itching. Now we will see miconazole and clotrimazole. Miconazole 2% and clotrimazole 1% applied twice a day for 2 weeks in pityriasis versicolor, 4 weeks in cruris, capitis and corporis. Uses: it is used in dermatophyte infections and oral, pharyngeal, vaginal, cutaneous candidiasis. Adverse effects are local irritation, itching or burning. Miconazole shows higher incidence of vaginal irritation and pelvic cramps. Triazoles. In this we will see itraconazole. It has broad spectrum of activity and also against aspergillus. It is fungistatic but effective in immunocompromised person. It does not inhibit steroid hormone synthesis and has no serious hepatotoxicity. Oriconazole. It is a second generation triazole and has high oral bioavailability and low protein binding capacity. Oriconazole has good CSF penetration and it is metabolized by the enzyme cytochrome P450 2C19. It does not require gastric acidity for absorption and has half-life of 6 hours. Uses: it is drug of choice for invasive aspergillosis. It is most useful for the esophageal candidiasis. It is first line for molds like Fusarium. It is useful in the resistant candida infections. Allylamines. In this we will see terbinafine. It is orally or topically effective drug against candida and dermatophytes. Pharmacokinetics. It is well absorbed orally. It is highly keratophilic and lipophilic. It has high protein binding capacity and has poor blood-brain barrier permeability. It has T half-life of 15 days and it shows negligible effect on cytochrome P450 enzyme. The adverse effects are nausea, vomiting, diarrhea. It causes taste disturbances. It has rarely hepatic dysfunction and it shows erythema, itching, dryness, urticaria and rashes. Now we will see uses. It is used in the dermatophytosis, onychomycosis and candidiasis. In dermatophytosis, it is given topically or orally for 2 to 6 weeks. In onychomycosis, it is first line drug and given for 3 to 12 months. Now we will see some questions. First question is: which antifungal drug is commonly used as a topical treatment for superficial fungal infections? And the answer is fluconazole. Second question is: which antifungal drug class inhibits the synthesis of squalene epoxidase, a key enzyme in the ergosterol biosynthesis pathway? And the answer is allylamines. Third question is: which antifungal drug class is primarily used for the treatment of dermatophyte infections? And the answer is azoles. Fourth question: which antifungal drug is associated with the side effect of hepatotoxicity? And the answer is itraconazole. And the last question is: which antifungal drug class is generally considered safe for used in pregnant women? And the answer is azoles. Thank you.